Good afternoon, everyone. Thank you for the kind introduction and for the invitation. I'm honored to be here with you. I'm from the School of Medicine at the Aristotle University of Thessaloniki in Greece, and I am the director of the Lab of Medical Physics and Digital Innovation. So for this talk, we're going to focus on technology and physical activities, so I'll try to give a blend of the various things we are doing, declaring my conflicts of interest, likely conflicts of interest for this one. So in summary, I'll just spend a couple of minutes saying why we're here and why we deal with all these things, then focus on systems for physical and cognitive enhancement, going forward on technologies for fall detection and prevention and the digitization of evaluations. And then I'll spend a few minutes on talking about rehabilitation technology and aerospace technologies, finishing off with champion technologies that we are designing. So the Lab of Medical Physics and Digital Innovation, which I'm honored to direct, is the oldest one in Greece and Cyprus. And it is the largest of the School of Health Sciences, but also of the university, which is one of the largest universities of the Southeast Europe, to be honest. We have more than 10 research groups focusing on various aspects of science and technology as applied to healthcare and education. And we run particularly with two ISOs. One of them is particularly involved in the systems that I'm going to show, some of the systems that I'm going to show later on. It's the ISO 13485 in specific. Our vision is to use technology or invent new technologies that are going to service society. And we honestly want to, from all these projects, we sometimes run more than 30, 35 projects at the same time, being more than 18 members of research staff. We have a motto of driving the societal impact of these research outputs. So either using technologies that are available on the market or creating new technologies or methodologies, we have the goal of supporting citizens' health and well-being, specifically vulnerable groups, for example, and focusing our efforts on servicing those. So I'll give you a few details of the infrastructure that we have and some of the unique facilities specifically for a university department. For example, we have a living lab infrastructure where we have different facets of digital spaces devoted to measuring life. So one of them is completely on active and healthy aging. It's a construction of a digital space within our laboratory in the university. On the left, the second one is based on a pathology clinic in a hospital where we measure digitally transitions of healthcare, exit notes or prescriptions to rehabilitation centers, etc. And the far right is something that I'll demonstrate that towards the end of my talk. It's a human centrifuge and rehabilitation living lab that we have constructed from scratch. If the video can run, I don't know if I service the video. I'll just prepare this for my student, just to give you a snapshot of what we are doing at the laboratory. This is Thessaloniki, the sub-capital, and the School of Medicine infrastructures. This is our laboratory infrastructures. Brand new spaces which we renovated 5 years ago, and we keep renovating. So we use a lot of technologies like virtual and augmented realities, 3D printed materials enhanced with virtual reality, empowered nowadays with artificial intelligence to guide learning. These are some of the lessons we use for teaching our medical students and dental students neuroanatomy. And we are in the process of finishing one of the unique constructions also, which is an immersive cube, which is going to host at least 5 to 10 learners or patients within this space and immerse them in this environment, whatever that environment might be. These are some examples from assistive technologies for elderly groups. The centrifuge I'm going to show later on. The living lab. I'll specifically show the software later on. And various citizen-focused activities. These are the Jerry Olympics that we run. I'll spend a few minutes later on rehabilitation and software and soft robotics. Neuroimaging with high density EEG or the MEG that we have of measuring the magnetic signals of the brain. So let me go into the first topic of my talk, which is going to be on systems for physical and cognitive enhancement. Back in 2008, we were dreaming of using the internet for improving the health of elderly people, 65 plus in those days, and creating systems for them that could enhance their body and brain capacities. So we were thinking of it from a neuroscience perspective, and a few years later we published this review in which we also had utilized the ancient Greek saying that you need a healthy body and a healthy mind if you want a healthy life. And in this specific article, we sort of postulated that cognitive activity and training might guide what is called neuroplasticity, while physical activity at the same time facilitates neuroplasticity. So you put these together, you will have a better result. Now, we wanted to prove that this is true, and therefore we sort of looked at various methods and studies, which were very sparse at those stages. This is 15 years ago, on doing interventions and doing them properly, basically. So we designed the system back in 2009, which was called long-lasting memories, which had utilized technology to train the mind and the body using software specifically designed in the form of serious games so that it can be fun as well for these persons. But the challenge obviously was whether these persons would be able to use these technologies at all, or it would be completely useless. And if they managed to use the technologies, whether these technologies would have any effect in confirming the outcome that we wanted to show, that the brain will improve, the capacity will improve, and things like that. So we ran quite a few trials in elderly care centers, in municipal homes, in individual homes, in societies. I think more than 400 people around the various centers that we had in Europe and in Greece participated in these studies. And so in 3 years' time, we managed to sort of have this evidence that I'll show in a couple of slides. So then we took this one and developed it further alongside with the technology. As the technology was developing, we were changing the technologies that were utilized in facilitating the various games and promoting the enhancement as it was. So we have two parts, cognitive enhancement software and physical enhancement software. For cognitive enhancement, we have a co-marketing agreement with Posit Science in the US and using the product called Brain HQ. But completing studies with them all these 15 years. For the physical one, we designed from scratch, as I said, an online platform which utilizes exercises in the form of games. It is still enhancing visual and depends on visual and auditory processing, and it's personalized. So it strengthens balance, muscles strengthening, balance, flexibility, and aerobic exercises. in a piece of software that is changing so that it fits um, performance as well. If the video runs, some of these aspects of the video games can be displayed. This is one of the latest versions of the software. Just a snapshot, it's not a proper video. So there are various games, and there are, of course, achievements that give points and etc. So we wanted to do validation and provide evidence right from scratch, from the beginning. At that point, 2010, everybody was just doing usability validation. It's usable, it's friendly enough, and all these things. We didn't stop ourselves in being satisfied with usability, but we wanted to do multimodal, multilateral evaluations, both in laboratory conditions, if the equipment is functioning, it operates in a friendly environment, we can tackle technical difficulties, but also in real life situations, or also in wildlife situations without any supervision at all, and on a large scale. I mean, hundreds of people, hundreds of participants, of course, both at the beginning, but also throughout these last 15 years have been using it. And we are investing in education and training, which I'm not going to focus in this talk. So what were the original results? We compared it to control groups, and the clinical psychological tests provided us evidence that memory improves and functionality improves as opposed to the control group. These are pre-post experiments, pre-post measurements, 2.5 months of exercise, 2-3 times a week, or 4 times a week combined. And these are results of physical capacity, where body fitness improves if you compare it to the controls. These are sort of more or less expected results, but we wanted to do more and ask whether the brain changes at all. So we measured the electroencephalograph of persons doing the exercise, before doing the exercise and after doing the exercise, and doing group analysis, and seeing if there are brain areas which might be enlightened because of this intervention and because of this change. What I like saying is that we see that brain noise is reduced after this intervention and exercise in specific brain areas. And we wanted to depict that as a sort of neuroimaging sort of result. But we also went along and did other studies, like how the brain networks and the connectivities of different regions reorganize themselves. The active control group that we used is on the top row, and the bottom row is the intervention group, which you see that the change that we see is in the beta band, which is the band which is considered responsible for all the moving and the bodily activity, while you see changes in the control group, which are in the low frequency bands, which denote a sort of a certain decline, brain decline, cognitive decline for that specific group after 3 or 4 months of re-examination of the brain. And this is a more sort of zoomed version, how the brain networks basically reorganize themselves following that systematic, I would say, intervention, because it's not just with 1 or 2, but it's a 2-3 month systematic intervention of cognitive and physical training. We wanted to represent this in various groups. These are the healthy groups on the left-hand side, and the amnestic MCI groups, and the mild demented groups on the right side, and how much of these connections exist in healthy, in amnestic MCI and the MD, and we can monitor basically the organization of the brain in healthy and diseased brains by just doing an EEG scan, basically. We sort of followed that specifically in those years, and we have managed to classify even before deep learning and artificial intelligence were very fond in these years. What we wanted to do also was to get out of these technological and games digital biomarkers for these exer-game interactions. So we got specific parameters from the games. I mean, how much is the angle when you move your left hand or your right hand? How much is your angle when you move your body in the balance exercises and stuff like that? And we wanted to follow these up and see whether they correlate, for example, with cognitive assessments. How much is the brain capacity, the cognitive capacity of subjects, and whether the clinical psychological tests that we have align with some of these results, and some of these results were indeed aligned with the results that we have from the execution of the games on average for those sessions. In the following years, we moved along with studying Parkinson's patients. We never published the Parkinson's studies, to be honest, because we didn't have a very good control group. These are similar results from brain imaging with Parkinson's after following the same intervention and the reorganization of their brains, again, following this intervention. We also practiced for a couple of, for 3 or 4 years, not a couple of years only, Down syndrome patients of various ages from 10, 12 years old up to 47 years old, categorizing them in specific studies and seeing whether the same kind of result could exist. The exact result that we found was that if you compare the Down syndrome patients following that activity before and after, their brain connectivity maps look more than the typical subjects of typical ages and typical development. So we published this in a very important journal of network neuroscience a few years ago, just to signify that some of these interventions might have actually some value when you do them in specific vulnerable groups like the neurodevelopmental disorders groups, and etc. So we sort of recommend this in the various societies, various organizations, infrastructures. In specific, I've traveled to Athens today, but my group, half of my group, in fact, is in the municipal house in Thessaloniki, doing this action with the municipal center and the regional health authority there, trying to welcome people to use the system and facilitate their exercise. So in parallel to what we are doing today now, they are practicing. These are today's photos, in fact, from the elderly people visiting the municipal office in Thessaloniki and doing with the facilitators that you see in red t-shirts these activities. And we will keep it open for the whole day, in fact, so that people familiarize themselves with technology and the motion and the bodily movement. Obviously, there exist many such software pieces, not a lot of systems combined, but we wanted to reiterate that evidence and validation of these software pieces is very important, and we have put that in our agenda right from the beginning so that we can make a difference. Now, switching to the second part of my talk, which is fault detection and prevention, by looking at gait log analysis and the digitization of the various evaluations that we do. You will agree with me that it's one of the very significant problems in the later stages of life is the falls. They can lead to fractures, but also they can lead to death. There is a very fun but very serious also at the same time saying in Greek, which I will not mention, but anyhow, more than 1 in 4 older people report a fall each year. This is worldwide. It's not a Greek finding, obviously, but you can, in fact, if you get those people that fall down in a bus, you can actually fall in a double-decker every year because of these sort of falls. And every day, I mean, not every year. So there is a global epidemiology of falls. It's probably the second leading cause of death from unintentional injuries worldwide, and accounting for more than 37 million falls per year, which are serious enough to require medical attention and hospitalization, perhaps. And there is a lot of risk factors obviously involved, behavior, but also physical changes, decreased physical activity and capacity, the environment, the infrastructure within the home, obviously the clothing, the equipment, the various habits, as well as medication itself can increase the risk for falling down and therefore the injury. People that fall down, they have this sort of increased fear of falling again, and therefore they decrease intentionally now their physical activity. So the physical ability and capacity also decreases, and therefore the risk of falls increases again. And they might fall again because of this vicious circle that you see of fear-induced reduction of physical activity, and therefore the increase of risk of falling again, etc. What can we do to prevent? Of course, staying calm and not panicking and all these things, but also the prevention tips, moving and staying active, keeping the bones strong, always stand up slowly, etc., etc. These are normal recommendations that our GPs would provide, obviously. What we can do from technology is to assist this and facilitate this. So we do gait assessment, which is a key indicator of functional capacity and balance. And we use parameters that I'm sure that in this audience you'll all be familiar with them: gait speed, length and pace of gait, symmetry and stability, posture and the use of different aids, single and double support times, swing times, and stuff like that. So I'll give a few examples of tests that we use. Sorry for the Greeks. 6 minutes walk test is one of those that we use. 10 meters walk test is something that we use. And we try to digitize this nowadays because what on earth, we are a sort of a digital sort of group. How would be if we couldn't do that? And we use platforms that could do time measurement, but also motion capture and analysis of specific data that they use. So there exist various technologies, obviously, in the market and also in the literature, technologies that analyze and record human movement. You see some of them here with various apps, with head worn or straps, or shirts worn, or wrist worn, or the various clips or shoe worn, different gadgets and sensors basically that read and record the human movement and can inform us of various things. There are motion recording technologies. I'm sure you would have seen them with the use of cameras and reflection pointers and markers. They are very accurate. They have a wider, of course, use in not only just our field, but also in cinemas, in video games, and things like this. But the negative aspect is that they necessitate a dedicated laboratory, which is very, very expensive. Similarly, motion recording technologies, which use depth cameras and to detect the motion. These are very friendly to use even at home, but they have at the moment reduced or diminished, I would say, accuracy, specifically when you do complex movements. There are also other detectors of measuring inertia, gyroscopes, accelerometers, and stuff like that. They are very portable. They have a very low cost. But they do have also limited accuracy in terms of, and compared to optical methods and other means. And I will also mention the electromyographs, which also can analyze and can measure electrical signals from muscles for the analysis of movement. They have very good data to give, but the complex data that are given out, they require very good signal processing methods to be able to give you some accuracy, which is not the best, but it's good enough to do your job if you want. So we try to utilize a number of those, and one of the pieces of software that we have utilized in the last few years is this Digital Souls, a specific software that we use for the clinical evaluation of patients with different moving disorders while they walk. Some gait analysis report that the software provides is something like this. It's a screenshot. Our corridor in the lab is like this, and so we are able to sort of do it in a very good way, digitize the gait and the walking, and therefore do a very good analysis after that. So we use this as kind of assessment, the hardware and the software, to record it and analyze it and evaluate key spatio-temporal parameters and gaits. This is a very short study, small study that we did in the last few months of 10 people, trying to see and compare them with Parkinson's patients, just to see which of the models that we might be able to use specifically for analyzing and exploring the different methods, specifically when we go into large data sets, could be good enough. The random forest is and the support vector machine for those interested in these data analysis were some of those that had got the highest accuracy and sensitivity in this way. So we try to sort of keep completing and collecting these data to see which of these features might be better fitting into our analysis and facilitate these purposes. But we also engage ourselves in doing a motion capture studio, which will facilitate a number of these studies and dedicated measurements that we have. In the lowest possible cost, of course. So these are some of the games that we design nowadays with the sensors and the cameras to facilitate this. This is work under development, so I don't have the final results to show how our software will look like. But anyhow, you get the look and feel of what we're trying to do. I'll now engage with a few slides on the rehabilitation technologies. One of my colleagues in the laboratory is a neurosurgeon. He is leading this rehab technology group, which is called BIRD. Long-term studies again. We looked at the spinal cord injury patients, and there was a publication a few years ago saying that even if they injure the spinal cord, the connection of the brain with the spinal cord, despite being fractured, it's still not fractured completely. So we might get a chance to rehabilitate this. And that was the claiming of this group, specifically from Switzerland. Based on that, we tried to design specific wearable sensors that could be worn like now they're a bit more improved. Obviously, this is a very early prototype that we had during the pandemic. That's why the mask. And to record the various signals from the brain. But the whole piece of software, you see another representation here, even a digital sort of equipment to measure the hand movement, the finger movements, and grasping capacity and stuff like that. But also virtual reality, which would facilitate the training of these people if they can move their hands, the physical training, but also if they cannot move their hands, the brain training, the imaginary movement, which is designed now to facilitate themselves. And if we have specific games that are prescribed for them to train themselves, then we can get the baseline of their working brain, and therefore we might be able to train them properly in imagining movement, and therefore detect this brain movement, brain willingness to move, and therefore move a robotic arm or engage the wearable sort of jacket that they wear so that it stimulates their hand to move. This is an ongoing study that we have for the motion recording and recovery survey with specifically spinal cord injured patients. These are some of the trainings we did with this patient. He can move his hand, but he cannot move, otherwise he cannot walk. So a number of such patients came to sort of record their baseline and allow us some of these recordings. I'll go and spend a few minutes with the Human Centrifuge Lab. I have lots of data to show here, but I will not show much more. This is based on aerospace and principles, aerospace medicine, and it's using basically a centrifuge, a human centrifuge. This is similar to what the astronauts are using when they are up in space or when they return back to Earth, just to get rid of the weightlessness that and its bad impact on the bodily function. So we utilize the same idea because the astronauts, without being attracted by the force of the Earth attraction, are similar to the patients which are lying in bed for a few weeks or months, because the body weight of the patient lying in bed is basically counteracted by the reaction of the bed, and therefore they have weightlessness if they don't get up from that bed. So a number of researchers thought 20 years, 25 years ago that perhaps these constructions might look beneficial to patients, specifically for rehabilitation. So we did. If the video works here, can you click on the video, just in case? This is something that we constructed based on a patent from NASA. And now you can see the center of the moving, the head is in the center and not in the periphery. We can experiment with this, and we have done in the last 3 years various experiments on dosage, as we say, how much, how often, how strong, how quick, and how long, obviously. So we want to find out what is the best composition of how long you should be there, on how many G, as we say, so that it's beneficial for your own condition. As you can imagine, we wanted to record a number of physical parameters and biosignals while they are on the human centrifuge, but also once they get out, once they get down. So there is a lot of equipment that we are using to measure brain activity, pressure, muscle activity, electromyographs and stuff like that. If these videos work properly, this is one of the earlier stroke case studies. So she didn't move, she was completely in card originally without moving the left side completely.
Σήμερα άλλαξε μπλουζάκι και το ψόφιο το χέρι, το άρρωστο το χέρι, λίγο το σήκωσα και το πέρασαμε στο μανίκι.
So a month after she has moved, she has the capacity, she says, to move her left hand even, that she couldn't even handle at all, she could not do it. So this is after 1 month of exercise. And this is now the left foot after 2 months of exercise, which she can do. The right foot obviously has the capacity to do it. So the last one is 3 months later on, when she can walk on her own and restore most of the left-hand side movement all over. This was just a case study. We are following it up with a number of patients and data in the last few years to consolidate this. These are just measurements of the sleep for some of these patients to see whether there is a relevance with the centrifuge as an intervention with sleep capacity and activity. Some of these results were published initially as case studies, but we are now collecting all the data to publish proper cohorts of patients. In the last 2-3 years, we have collected quite a few hundreds of such patients. Finally, and concluding, I will also show some of these applications repurposed, I would say, for champions, enhancing champions by virtual coach cognition, basically. We focused on football here because the data we used were from football for motion attendance, and we wanted to see whether cognitive training on how on passing the game on the passing game basically by detecting peripheral vision and accurately passing on the ball to somebody else could have an effect. So we designed specific pieces of software, augmented reality, that could train yourself from data from FIFA in the game. So we borrowed the data that were freely available from the FIFA games, and we tried to modulate the game and the passing game based on that data so that somebody can train them himself or herself based on these movements, basically of actual players in the real game. So we wanted to utilize this for, this was designed during the pandemic, in fact. Then we are at the process of getting a patent and completing a spin-off within the university structure so that we can commercialize it in a way and exploit it commercially. I mean, it's a research result with specific teams. The product is called Neurofootball Coach, and it's trying to receive some funding from venture capitals and stuff like that. So to complete and conclude, I have tried to show you some of the interdisciplinary research and approach we have with new technologies for cognitive and physical empowerment, for some rehabilitation, but also for professional training by repurposing some of these studies. I wanted to reiterate that most of these are based on neuroscientific approaches on their design, and therefore then the software is alongside those considerations, designed in a proper way and tested in a very sort of detailed way so that it can validate itself. And we do that across the life conditions, across the life ages, and across professionalism spans. And therefore, we want to emphasize how important this is, that it's not only on a specific target group, but it's widely available, especially if we redesign or we readapt it. And I would like to thank you for your attention.